after my talk you get to go home. So I will try to be as brief and concise as possible. Over the past 9 years, I've been working in clinical trials in achondroplasia, and there has been a lot of really very interesting information that came about very recently, showing very exciting results. You probably already heard that achondroplasia is the most common form of short-limb dwarfism. About 120,000. Sorry, I guess you were not. Okay, 1 in 20,000 incidents is autosomal dominant, and 80% are new mutations. And interestingly, these mutations happen in the FGFR3 gene, and this is a very unique nucleotide, the most common mutation in humans. No one really knows why this is the case, but it's a very interesting example. And 98% is the 1138 G2A mutation. This happens in the transmembrane domain of the FGFR gene. Achondroplasia causes short stature, rhizomelic shortening, meaning the proximal part of the arm, brachydactyly with often a trident deformity, which is this unusual appearance of the fingers. These patients do have large heads with macrocephaly, frontal bossing, and mid-face hypoplasia. So the final height is short, 132 centimeters in male, 124 centimeters in female. So these patients do have short stature, among other things. This is just the brachydactyly on a patient with achondroplasia, and then you can see this shortening of the metacarpal and phalanges. So achondroplasia can be recognized clinically, but also radiographically. So on the left, you have a very characteristic pelvis for a patient with achondroplasia. Any pediatric radiologist can look at a film and say, this patient has achondroplasia. You can see this unique appearance of the femur with the scoop appearance of the proximal aspect. And you have sort of a trident appearance of the pelvis. Very characteristic, all patients with achondroplasia have spinal stenosis, and typically you will see that the interpedicular distance narrows as it goes down, and should be the opposite. It should always widen. And on the right, I put, this is an example of, a 3D CT scan showing the foramen magnum, which is this particular area. It's extremely small. I unfortunately couldn't find one to compare side to side, but it's very, very small, and this is what causes often issues with craniocervical medullary junction, narrowing and compression that oftentimes may lead to very severe complications. So, what is the role of FGFR3 in bone? So bone can be formed by two ways. Intramembranous formation is direct mesenchymal formation, but most of the axial and appendicular bones are formed through the mechanism of chondrocyte proliferation. Chondrocyte proliferation requires a number of different signaling and molecules, and you have molecules that drive the growth up and molecules that drive the growth down. For endochondral bone, the most important players are Indian hedgehog, or IHH, PTH receptor protein, and the Wnt signaling molecules, so Wnt5A, that drives the growth up. FGFR3, on the other side, it does the opposite. It puts the brakes on growth. So actually has an inhibitory action over chondrocyte proliferation. And as bone form, which start as a sort of a cartilaginous structure, you have different zones that go from the reserve or resting part of the of growth to proliferation and then to pre-hypertrophic and hypertrophic. And as the bone comes down in these stages, then it becomes vascularized. You go through apoptosis, and then the bone is formed, and that process continues to happen over the years of bone growth and development. So the FGFR3, as I said, is what put the brake on this particular process, and it is done by the action of the fibroblast growth factors, 9 and 18 mainly. So when we have abnormalities of FGFR3 and variants, pathogenic variants in the gene, you can have many different types of disorders. I'm not going to spend time on the other two, but suffice to say that we already mentioned achondroplasia, but you have other conditions like hypochondroplasia, which is milder manifestation of the FGFR3 mutation that is similar to achondroplasia in some forms, and then you have the thanatophoric dysplasias caused by either mutations in the immunoglobulin domain or the tyrosine kinase domain. This is a cartoon of the FGFR3, and then you can see that, imagine this is a molecule that is anchored in the cell. The transmembrane domain is the one that is typically mutated in achondroplasia, and then you have the extracellular or the immunoglobulin domains and the intracellular of the tyrosine kinase domain. And depending where the mutation occurs, you end up with a different type of phenotype, including thanatophoric dysplasia 1 and 2, and Sadan, which is a more severe form of achondroplasia. This is something that I usually show because remember that FGFR3 is a receptor, but it requires that these receptors that are monomers come together and function as a dimer. So, and this is done by this FGF that comes and starts the signaling, and then go through the signaling to the tyrosine kinase domain that send the information, down to the MAP kinase pathway. So whenever this mechanism is on, that is when the growth of the chondrocyte proliferation slows. So you have, as I said, you have the growth going upwards, and this is going downward. So we do now know that the mutation in achondroplasia is a gain of function mutation. So what happens in achondroplasia? As I explained to you, you have short stature, but it's more than that. You have stenosis of the spine. You have cervicomedullary compression, which could be more important in the first 2 years of life, and that can even lead to sudden infant death. You can have sleep apnea. You have bowing of the lower extremities, and as you grow older with this condition, there are other problems, including cardiovascular disease, hypertension, and obesity. So the treatment for many years has been only symptomatic. You deal with the complications of your compression, whether it's up in this cervicomedullary junction or down in adults that have lumbar stenosis. More recently, there have been a lot of limb lengthening procedures that still are common. They have evolved over the past 10 or 15 years. But now, all of a sudden, we have these very interesting therapies, and one of those is already approved and is in the market. And I will go over some of these. These are the cartilage natriuretic peptide. There was a trial by Pfizer that was a soluble FGFR3 receptor, and I'm not going to spend time on that because it really looked very good in animal models, but it was a disaster on patients. So it didn't work, and the trial is closed. And now what is coming is the tyrosine kinase inhibitors, which is one of them is way into phase 3, and others are starting to come. And I'll touch up on those very briefly. So if you remember from biology and physiology, the natriuretic peptide is a family of peptides, and there are 3 different types. One is for the heart, the other one is for the brain, and the C type is for the cartilage. So their mechanism is actually activating the guanylyl cyclase, specifically the guanylyl cyclase B, which is what is base for this particular therapy known as vosoritide or Voxzogo. So this is something that was serendipitously found about 25 years ago when a group in Japan was working with this CMP, and they realized that using mouse tibia cultures, if they were left in this solution that had CMP, they saw an increase in their growth. And lo and behold, they realized that this was at the extent of the areas where there was cartilage or chondrocyte proliferation. So that already gave them the clue that something was going on with the CMP and causing this particular growth. Moving forward many years later, what it was done is some people were looking at how the CMP or expression of CMP could change the chondrocyte proliferation in mouse model with achondroplasia. On the very top of this figure, you have a wild-type mouse. On the second, the ACH corresponds to a mouse model for achondroplasia. And on the last one, you have a mouse that has been overexpressed for this CMP. So as a result, they found that you could rescue the defects of chondrocyte proliferation, and that you can rescue the length of the different bones. So that starting to show that the CMP had an important role and could potentially rescue this phenotype. So then it came, this drug known as vosoritide, now has been approved to be used in humans in most countries. Vosoritide, what it is a drug that acts, as I mentioned to you, over the receptor that is acted through the GCB mechanism, and then indirectly what it does, and this the receptor, I forgot to say, it's the MPPC, and this natriuretic peptide receptor basically gives the signaling to the MEK pathway, and that what it does, it actually puts a brake on the tyrosine kinase pathway. So it's an indirect way by which it decreases the signal of the tyrosine kinase, and that restores some of the chondrocyte proliferation. So vosoritide is a recombinant CMP. Is slightly longer. The CMP only lasts a few minutes. The vosoritide lasts, I believe, about half an hour or 40 minutes. So this is a much longer acting drug. And then the studies that have been done, and I will show that use a dose of 50 micrograms per kilogram actually can restore some of the heightened annualized annual growth velocity. So this was from the clinical trials. This is from one of the papers that showed early on that the group in orange are the placebo patients, and in blue are the ones who received vosoritide. This is the initial phase as they were studied, and then it shows that at 52 weeks there was a significant difference in growth for those who were receiving vosoritide. And you have a breakdown. It's a long graph, but I'm not going to go over that. There are differences for sex, age groups, and also time and stage. But ultimately, it was found that about 4 years of age, data collected later on, that the growth average for those patients that received vosoritide was approximately 1.57 centimeters per year over the expected growth that was expected for their condition for achondroplasia. These, I apologize, it says 8 years, but the lower part is 8 years. The first part and the graph shows what happened in the study early on. So you have a first period, 6 weeks of patients who were in a natural, 6 months when in natural history study. Then you have 1 year patients with half with placebo and half with the drug. So the placebo are in orange, and the ones in the drug receiving the drug are in blue. And then there was a continuation for another year, and the ones that were on placebo crossed over, and you can see that started growing and catching up to a similar level than the ones that were receiving all of the time the drug. So essentially the growth velocity in both groups, the one that received the drug all of the time and the one that received placebo and then drug that crossover were significantly significantly working, and that showed that indeed there was no doubt that this drug was causing an increase in AGV. The 8-year data, which is the one in the lower part, shows actually that the increase is a little bit more. It's about 155 centimeters per year in females and 1.98 centimeters in males. So a lot of this data is slightly changing as they collect more data. The numbers appear to be probably a bit more firm. But the interesting part is all of these patients continue to grow regardless. It's not that they grow and they stop. They continue to gain height and AGV. And the interesting piece of data is also that now some of these patients show that there appears to be some improvements in proportions. Remember that this patient had disproportionality because they have shorter limbs. So how do we know that this is working? Well, this is from the first clinical trial that showed that this patient has larger urinary concentrations of cGMP, because this is the guanylyl cyclase, so this particular action causes some of this increase in cGMP. So it's a marker that this drug was actually doing what it was supposed to do. And then there is another marker that is called collagen 10, that is a marker of chondrocyte proliferation. When there is an increase in proliferation, there is an increase in collagen 10. So, and these actually show there were different dose escalation. 15 is the one that was finally used, which is the one in blue. and then you have the different cohorts for the different drug concentrations. So what happened with adverse events? The adverse event exists for vosoritide, but they are not that significant. You can see mostly site injections, reactions, and erythema. The important part that the drug was relatively safe with no disproportion created beyond of the disease. No cardiac problems. Remember, it's a natriuretic peptide, so it does cause in some patients a transient decrease of the blood pressure, but no significant if these patients are hydrated. No marked allergic reactions, and many patients developed antibodies, but that did not prevent them from growing, so they continued to grow. So more data will be needed on this particular group. The group that I show you is 5 years and older. This is 5 years and younger. And this trial was divided in 3 cohorts, 0 to 6 months, 6 months to 23 or to 3 years, and then the 2 to 5 years. So the interesting part about this trial, and I'm not going to go into all of the details, is that the growth in this patient was much less than in the older population. So you have an average of 0.8 centimeters per year over the expected growth. And there was an interesting piece of information that showed that patients in the cohort 3 had an increase in their facial volume, as well as the sinuses and foramen magnum compared to the older children in that particular cohort. So unfortunately, there was no statistical significance because the margin, the numbers of those areas were very extremely variable, and that it was not enough data to really see a statistical significance, but clearly there is a trend. In terms of side effects, I think that it's a little bit different. In this particular study, one child died. You need to keep in mind that these patients, especially in the first year or 2 of life, the risk for sudden death increases. In this particular case, this is a patient that had problems with reflux, obstructive sleep apnea, and he was receiving supplemental oxygen. And in addition, this patient had multiple respiratory infections and an RSV that required hospitalization. So there were a lot of things going on in this particular child. So what else is going on? Well, there is another interesting trial going on, which is from a company called Ascendis. This is a TransCon CMP and has a name that is being now called maybe pegritide. This is a long-acting peptide. So essentially, this company has a carrier that adds a linker and then adds the CMP. And as the CMP is released by difference of pH and temperature, it becomes active. So the advantage of this particular drug that is given injections once a week rather than once a day like vosoritide. And there are phase 2B and phase 3 trials underway, and there are some interesting results that I will show you in a minute. They did initially the phase 2 study. It was an unusual phase 2 because it was dose escalation and also placebo drug, which is kind of unusual to mix all of those 2 things. And they used 4 different doses. They realized that the dose that was working the best was the highest dose, and they had not enough children really in that particular cohort. So they had to open up the phase 2B and add more children. But they found that there was an interesting trend in growth, and then they ended up having some data that shows a 1.07 centimeters of growth over the expected. The only problem is you cannot compare this with the vosorotide because this was, I'm sorry, I wasn't looking at the, what did I do? So the problem is that this particular trial was including children from 2 to 11. And remember I told you that 0 to 5, so what I was saying is that the initial article that was showing this transplant CMP, it was essentially looking at the children from 2 to 11. And remember I told you that for vosorotide, they had one measurement that from 5 to 11 that was completely different to the one that is 0 to 5. So one was 1.57 centimeters and the other one was 0.87. Have to be the last talk. Maybe the universe is telling me something. Can't figure it out. Okay, so what I was going to show you is that this week, actually the company Ascendis showed some of the preliminary results on this particular trial. And they do have patients still 2 to 11 years old, but they have enough patients on each cohort to be able to say what happens. So what they now do have is a total of 57 patients that received the drug at 100 micrograms per kilogram per week and a weekly dose, and there were 27 that were on placebo. So this is the analysis that was done at week 52. So the primary was to obviously look at efficacy and also look at annualized growth velocity. Secondary was to evaluate the transplant CMP on the height Z-score, and then also evaluate safety, looked at stratification, and this study has been going on in many countries, the US, Canada, Denmark, many European countries, Australia, and New Zealand. And I understand there is one clinical trial going on in China with this particular drug. So I apologize that you cannot see what I'm talking about, but I will try to tell you in the best way possible. So at 52 weeks, the annualized growth velocity, and this is information from the company. This is not been published yet because it just came from the analysis. The annualized growth velocity at week 52 show the patients that have been receiving the CMP had a 5.89 versus 4.41 the placebo, which was statistically significant. This is actually the height C-score, and this is actually quite nice because it shows that the patients that were on the TransCon in 1 year basically achieved a 0.3 height C-score compared to the ones who were on placebo. And on the right is actually, I like it because it's basically the same numbers, but they're plotted against the CDC high score. So essentially showing a negative high C-score for those who were on placebo, and then they make a point that essentially the rate of growth is almost comparable to children of average stature. So, and this is something that I guess you can compare more with what Voxzogo has, and that is the increase per year of those who have been receiving the CMP. The ones who were 5 to 11 years was about 1.78 centimeters per year, and the ones from 2 to 5 are at 1.02 centimeters, which is kind of similar to what you see in Voxzogo. So right now there is an infant trial, which is 0 to 2 years, that started about 3 months ago. So we have actually several children for that study, and we will know in 1 year what happened to this particular group. The one thing that is interesting is this drug doesn't seem to cause any type of reactions, and only a few patients have side reactions in erythema. So lastly, I'm going to give you a very short comment about tyrosine kinase inhibitors. So you remember the pathway, and the inhibition of the chondrocyte proliferation passes through this tyrosine kinase. And there is a drug that is already in phase 3 studies that is called infigratinib, and this is the pan-tyrosine kinase inhibitor. The problem is that it also inhibits other, not just FGFR3, but FGFR2 as well, and it can cause hyperphosphatemia. This is something that is well known because these drugs have been used for cancer. I will skip these, but essentially these are studies that were done on mouse model, and for this particular drug, we still do not have, this has been more than a year and we're still waiting for the results on these studies. They had a similar issue. They were using many different drug concentrations. They stuck to cohort 5. They had to increase the cohort, but they came out with a number that it says that is 1.52 centimeters per year on children 5 years and older. The difference with this medication is that it's oral. I do have some concerns, however, and the concerns is that with this particular drug, you have, most children seem to have an average growth, but some children seem to have a fairly significant, I would say almost excessive growth, and others do not respond. In fact, when they publish this information in their website, it actually says that only 91% of the participants had an increase at 18 months, which is a little bit concerning. If someone, it's an oral medication, but if you tell the family, well, you have a 10% chance that your child will not grow, that can be a problem. So, and these now is followed by many other companies. Sanofi is the next one that is in now advancing clinical trials. They have this drug, SAR442501. It's a monoclonal antibody that binds to the IgG2 domain. and essentially inhibits the ligand binding. So no FGF getting to the receptor, then the action inhibits directly the tyrosine kinase action. So this is just starting, and we will see what it shows. So in summary, CMPs are very useful, obviously, for achondroplasia, and they becoming standard of care. Voxzogo has been approved already in many countries, in Europe, Australia, in Japan, in some at birth, in others over 5 years of age. It's fairly safe with no toxicity. The annual growth velocity appears to be between 1.5 to 2 centimeters, and these are for patients who are 5 years and older, and less for those who are 0 to 5. Even though there was no worsening in upper lower body segment ratio, now there is data that appears that it is causing some improvements. And lastly, now we have the TransCon CMP that appears to have very similar effects to the ones shown by Voxzogo, and also has a similar pattern of growth for the children who are in the lower ages. And the tyrosine kinase by BridgeBio, infigratinib, hopefully we may see results. There is a skeletal meeting this past week, so hopefully they may have shown more data. And the Sanofi is coming up, and there is a new one in the market now that will start trials called Tyra 300, and that is also an FGFR inhibitor that has been used for urothelial cancer. So a lot has happened, and we went from no treatments to all of the companies knocking each other just to come with drugs to the market. I think it's great, especially great for the patients. I have some really very nice stories of patients that have been in these drugs, so I feel that this is an exciting time for all geneticists, pediatricians, and endocrinologists, so, and the families, obviously. Thank you, guys. Thank you very much.
Thank you, Dr. Krishna. Well, I think that was an amazing closing plenary session. I think you really spurred 3 outstanding talks which highlight the themes that I think have been recurrent throughout the whole meeting. I think Professor Holmes talked about how we have genetics testing moving into screening.